So one of the disadvantages of sitting up here is you can't see the cool slides and pictures. So I was like, oh, I see these cool people. So anyway, thank you. I too am honored to be here and so excited to hear about all the wonderful things that are happening in the field. It's been a long time I've been working in the field, and wonderful to hear the progress. So who we are was mentioned a little bit in my bio. We have about 630 beds, 24 off-site clinics that serve over 500,000 ambulatory visits a year. We're the only medical academic center in New Mexico and a larger region's level 1 trauma center. We have about 6,000 employees, and about half of our population lives in poverty. In New Mexico, race and ethnicity are reported to a little bit differently. So about half of our population self-identifies as Hispanic or Latino, about a quarter white or Anglo, about 10% Native American from a variety of different tribes. And then the other smaller populations make up that other 15%. Health literacy is relatively new in the organization, and it's currently placed in an office which is also relatively new. In 2010, the Office of Diversity, Equity, and Inclusion was created, and its express purpose was to make sure that all patients receive the safest, most effective, and most sensitive care, regardless of their race and ethnic identification or identification with any other group identity. And then when health literacy was brought in, my position created just a year ago was brought in, then I like to also add that without regard to their health knowledge or their literacy abilities. So that's currently where my position and the health literacy efforts are based, is in that office. One of the main things that we're doing, and I'm starting with the attributes that we're working in the most intensively, 6 and 8, and then we'll go to the others that we're working in on a smaller basis. So with regard to the interpersonal communication, probably one of our greatest successes to this point is a strong and vibrant interpreter language service program. We have 20 on-site interpreters that are, 16 of them do Spanish, 3 Vietnamese, and 1 Navajo. And then we serve about 25 other language groups, and those are served through video and telephone interpreting. And this is a vibrant community of people that are very dedicated and haven't always been there. More about that later. Another factor or component of our efforts to improve interpersonal communication are just trying to raise awareness across the organization of how different our language is, the typical language that providers speak, versus plain language or living room language, and just getting people to understand that through a variety of methods to raise awareness. And another recent thing that we've done is put up a plain language thesaurus, which is maybe the most comprehensive one around. It's the CDC version, and I then added the thesaurus I'd been working on for about 20 years that I shared in my workshops, combined those two together. So it is available on the internet publicly. We also are just beginning a Teach Back initiative, so I'll be calling on some of you to find out a little bit more about how you got started. Attribute 8 is the other big area that we're working in, and this is just really focusing on making our printed materials easier to understand, in addition, not just putting them in different languages, but getting them down so that they're easier and more actionable. The first part of this is employing staff with health literacy expertise. Fortunately for me and for my hospital where I'm working now, I was a consultant, like they said, for maybe 18 years, working around the country, but had done very little work in New Mexico. Been volunteering on the task forces there at the hospital, and then a year ago they created a position, and I applied and got it. So I'm now able to focus in one organization. Just been there a little over a year, so learning how to make organizational change in an organization that was already beginning to think about health literacy issues but hadn't done a lot is where I'm placed now. So it was a really nice fit. One of the other things that they've provided is additional resources for me to hire professional plain language editors and a graphic designer that have special training and expertise in readability and reading ease to kind of ease the load of documents that have come in for me to review. That is a part of my job description. It's not supposed to be the whole thing. I'm supposed to be building system change, but they've also said, yeah, you can edit documents, and so a lot of people are bringing those to me, and that's been a challenge to try to get everything done. One of the things we're working on is with that graphic designer, she's created kind of a new style, a new look for standardization, branding a little bit, if you will. And you can see the before and after versions of information put into the new style guide. We're piloting at this time. It may not stay that way, but at least we're trying to get something, and we're going to make sample materials and put it up on our intranet so people get a sense of what good looks like, because that's been a real barrier, is people, they don't know what we're talking about when we say plain language. So we'll be designing a more formalized system, or are in the process of designing that, for people to submit their documents. Right now it's voluntary, it's pretty informal. I get back to them as I can, but down the road we do want to have a mandatory system, at least for all new documents that are created. So I'm training a team of people to be document reviewers with me. I'm not sure how that's going to all work out, because there's just a few of them, and as you all can imagine, thousands of documents. In the meantime, I've created some tip sheets that I ask people to work their way through, apply what they can from those before they submit documents to me for review and revision, and refer them also out to that plain language thesaurus that's up there. Our materials are all supposed to be translated in our other two languages, the Spanish and Vietnamese. They're not all there yet, but there's a real strong effort for that. And so what I'm trying to do is figure out how to bring the health literacy and making the English version easier and more focused, more actionable before it goes to translation, because when you have something, written very poorly in English and it goes to translation, then you have something that's also still very poor in those other languages. For attributes 1 and 2, looking at leadership, this is one of the strengths of our program, is we do have a few top key leaders. Not everybody's on board, but the few who are, as others have said, they're passionate, they keep putting it out there in front of other people, supporting resources from my position, supporting me when I say to somebody, we really need to change this document, and the provider is saying no. There's still some tension there, but at least they're behind me saying, no, you guys, we really do need to look at this. Early on in these efforts, we did an organizational self-assessment, which gave us some very good data about where we need to go, and there's plenty of areas for work, especially since this initiative is so new. For preparing the workforce, this is another major area of work. There's a key physician on the medical school side, and I'm working and speaking at the hospital side. We're doing a lot of presentations to people within our spheres of influence, trying to raise awareness. And again, we're just at the point of raising awareness. I teach a 2-day intensive class, a workshop that I've taught for years around the country. 70 people were trained in the first year, which to me didn't sound like much, but everybody at the hospital said, oh no, that's awesome. That's really way more than we thought. So, okay. We have a mandatory online competency that was developed before I came on board. And our Health Sciences Center library has put up an entire website on health literacy. I gave them a giant bibliography, and they just put it up with all kinds of tabs and links to just about everything anybody could want to know. So anybody in our organization, and any of you, it's available publicly, can get on and have almost direct links to all kinds of things related to health literacy, kind of a clearinghouse. So that's been really helpful. Attributes 5 and 7, trying to meet needs for access. We're really working hard to improve our overall environment. Improving signage is still a real challenge for us. Before I came on board, that effort was begun. I'm officially on the wayfinding committee, but they don't really listen to me very much because a lot of the decisions have already been made, so that's still a struggle. I'm really hoping we can move forward on that. Our patient financial services, they do an excellent job helping patients navigate and getting the help they need. We also have a special office of Native American Health Services, and they also do an outstanding job helping our Native American patients navigate their way through. We also have a new patient portal, which, as many of you know, the vendors are generally not set up to, that the information is not very editable. It's not very, we can't really change it. Even in the English version, I was allowed to edit some of the text, got it down to about 8th grade level. Other texts, they said, no, this can't be edited, and we certainly have problems going across languages. In terms of the high-risk situations, I'm working actively with a doctor of palliative care. We're revising the advanced directive forms, working on consent forms with some other people in the system, and revising medical intake forms. Actually, the consent forms one of those was done by a team of doctors who got together inside the system, created something that has been approved and is being used, but other docs in the system don't like it. So some people are using it and some are not. So what generated the interest, as far as I can tell, and from the kind of the historical report I got, since again I've only been there for a year, was just some key leaders really becoming aware of communication problems and hearing stories, and then the national forces for change, the reports, the standards, the Joint Commission, these kinds of things. And they got it and said, okay, we really need to make some changes. So they went out and started talking to their colleagues and are prodding and encouraging. But probably the most significant thing that happened for us was in 2005, the community filed a lawsuit for demanding language access because we were not doing a good enough job providing services for people who speak other languages. So that's when we really got going and really started looking at communication issues and took that very seriously. The leadership who were involved were just transparent and non-defensive and said, yeah, you're right, you guys, we really need to do this. So they worked very closely with the community, and it's been a huge success. So the strategies that have moved us forward, like many people have said, key leaders, in specifically figuring out ways to link, in talking to other leaders, link health literacy to the safety, quality, patient satisfaction, and cost savings. So they keep hammering on this and using stories, videos, and vignettes and that kind of thing to tug at the heart and also to touch the mind. And the leaders continue, these people who are really key, continue to challenge people across the organization at all levels, just saying, we can do better than this. Guys, we can do better than this. So they keep putting it out there and framing the messaging in really wise ways. They've provided commitment, tenacity, and focusing on that messaging again and again. And in that response to the lawsuit, again, that's just really facilitated change because we had to pay attention. So when it happened, they were, I'm sure, very freaked out, but it really gave them the kick in the pants they needed to keep going. Coming health reform, the impact of new patients. We expect lots of new folks to come flowing in. We're the system that best serves the low-income population. New Medicare readmission policies, those kinds of things have kept us going. Factors that are barriers, resistance to plain language in general, plain language as a philosophy, but also just in using plain language, and a lot of providers just having that pride in their own vocabulary and not wanting to let it go. Those same people also, and many others, just don't believe or don't understand there's really such a mismatch between what our system demands and what patients can actually navigate. They just don't believe it. I showed a video at a meeting with a doc a couple weeks ago. It was Tony Cordell. Most of you know that story about Tony Cordell. And when it was over, he said, I don't believe that. You stopped the video before it was over. And I said, well, no, actually I didn't. And it's really true. She's a personal friend of mine, and it really did happen. But he just couldn't wrap his mind around it. Never would believe that it actually had happened. So competing priorities also have been huge. Just in the year that I've been there, we had a Department of Health CMS visit, Joint Commission visit. The Department of Health came back because we had some issues that needed to be resolved. Huge amount of work went into that, just happening back to back. We were implementing some changes in our electronic health record, combining 4 disparate parts of our University of New Mexico system into one health system. Again, just huge things happening. All of this really kind of coming down to everybody that works in the system, as in many of yours, is just overwhelmed and on overload. And when I come in and say, hey guys, do you want to learn how to fix your materials, or you want some help, or come to my class? And they're kind of like, I really just don't have the energy to even wrap my mind around that. So that's been a real challenge. But at the same time, we have people who are getting it and who've seen the issue, have a name for it now, and have a lot of enthusiasm. So someone said earlier, be careful what you wish for, and that's where I am now. Just in the last 2 or 3 months, the demand has just outpaced, my one position, and so we don't have the resources really to So I can't respond like I want to, and so I'm a little concerned that that's going to impact people's desire, stay engaged with me as well. I write to her and she never writes back. Well, yeah, you and 80 other people, so. And then just resistance, not just to plain language, but to change in general, I think is really tough. A lot of people. I created a consent form. It was in use for a while. Joint Commission came, called it best practice, and then after they left, the provider said, you know what, we really can't use that anymore. It's just too plain. It says you might die instead of mortality, and you can't do that. So we're now back up to the grade level 16 form that we were using before. So those things happen. Changes maintained, like everybody said. Leadership support's still there. Regulatory requirements are still there. I'm going to be there for a while. These other things will continue. And then I just added at the end some kind of call to action type things that I think are important for our field to look at. So, all right, that's all. Thank you.